Neuromuscular blocking agents. Muscle relaxants can be divided into two groups. The first is non-depolarizing drugs such as Uranium and Uranium. These drugs are competitive antagonists of acetylcholine at the neuromuscular junction. The second group are depolarizing relaxants. Only Saxomethonium remains in clinical use. Saxomethonium mimics the action of acetylcholine at the postsynaptic cholinergic receptors and causes prolonged depolarization at the neuromuscular junction, resulting in paralysis. At the neuromuscular junction, acetylcholine is released from the motor nerve ending in response to an axonal action potential. Binding of acetylcholine at postsynaptic nicotinic receptors results in depolarization of the muscle end plate and influx of calcium ions into the muscle sarcoplasm, causing muscle contraction. Acetylcholine is metabolized by cholinesterase in the synaptic cleft. The first non-depolarizing muscle relaxant in clinical use was curare, which is a plant derivative. It's notably used by rainforest tribespeople to coat their arrow tips. They obtain the curare from the skin secretion of tree frogs, which eat the plant that contains the chemical. Non-depolarizing agents act as straightforward competitive antagonists at post-junctional acetylcholine receptors. They prevent acetylcholine binding, and so there's no endpoint depolarization in response to an action potential. Uranium has really cornered the market for anesthesia in terms of non-depolarizing relaxants. It's an aminosteroid agent. It comes in amps, 10 milligrams per mil. Intubating dose is 0.6 milligrams per kilogram, so normally 40 to 50 milligrams, 4 or 5 mils, achieves intubating conditions within 2 to 2.5 minutes. A higher dose, 1 milligram per kilogram, can achieve intubation conditions within 60 to 90 seconds. It has a half-life of 14 to 18 minutes, and a clinical duration of action before top-up is needed of around 20 to 30 minutes. It's metabolized in the liver, so its effect is prolonged in liver failure. It's completely reversible with Sagamedex. Even with very profound block, high doses of Sagamedex will reverse a blockade with Uranium. And it's a very clean drug, minimal side effects, commonly causes pain on injection, and also anaphylaxis, about 1 in 5,000. Uranium also comes in 10 mg per ml ampules, intubating dose 0.5 milligrams per kilogram, so roughly the same as Uranium. Intubation conditions in 2 to 2.5 minutes. Clinical duration of action much the same as Uranium. Metabolism is different. It's metabolized in the plasma by spontaneous breakdown at body temperature. This is called Hofmann elimination, and a bit of ester hydrolysis. It's not a steroid agent, so it is not reversible with Sagamedex, which is a significant downside. Side effects are histamine release, especially if it's injected quickly, resulting in hypotension or bronchospasm, and it can also cause anaphylaxis. Cis-atracurium is the R-cis isomer of atracurium. It's more potent and has a longer duration of action. It doesn't release histamine. It doesn't reverse with Sagamedex. It's metabolized by Hofmann degradation, so there's no accumulation in renal failure. It's really only used by infusion in ICU in patients who have difficult ventilation. Pretty clean drug. It does cause anaphylaxis. Saxomethonium is the only depolarizing muscle relaxant in clinical use. It's an agonist at post-junctional acetylcholine receptors. Stimulation by Saxomethonium first causes uncoordinated muscle contractions called fasciculations, and then a persistent depolarization that results in paralysis. It comes in 2 ml ampules, 50 milligrams per ml. Intubating dose is 1 milligram per kilogram. Normally just give an amp. It has a rapid onset time, 45 seconds to a minute, and a short duration of action, 3 to 5 minutes. This can be problematic because you may only get one shot of intubation while you have full muscle relaxation. It's metabolized by plasma cholinesterase, and it has a no reversal agent. Neither neostigmine nor sugammadex are effective. Saxomethonium's short duration of action, irreversibility, and long list of side effects mean it has fallen rapidly out of favour over the past decade or so. Side effects: it's an MH trigger agent. It causes anaphylaxis fairly frequently compared to other muscle relaxants. It causes potassium release, 0.5 millimoles in sort of healthy people. If you have a denervating spinal cord injury or something like motor neuron disease, or have had a severe burn, it can result in huge amounts of potassium release, which can be fatal. It causes bradycardias with repeated dosing, increased cranial pressure, increased intraocular pressure. It causes muscle pains, a bit like delayed onset muscle soreness if you've had a heavy gym session, which can prevent mobilization of patients post-op, particularly in young muscular people. And if you have a genetic defect in production of plasma cholinesterase, sucks can last for 3 or 4 hours, and you need to keep patients asleep while this has happened and realise that it's happened. Sugammadex is a reversal agent for aminosteroid muscle relaxants, Uranium and Uranium. It encapsulates the muscle relaxant molecule, rapidly and permanently deactivating it, and it can be used to reverse even deep blockade if given in high doses. It's excreted by the kidneys. It's got a very clean side effect profile, very rarely causes anaphylaxis. Of significance, it also encapsulates steroidal hormonal contraceptives, and these may be ineffective after receiving sugammadex. So any woman who's received sugammadex should be counselled accordingly. They should obey the 7-day contraceptive rule, i.e. use barrier methods for 7 days following administration of sugammadex. Neostigmine is an anticholinesterase that can be used to reverse block by all non-depolarizing agents. Inhibition of cholinesterase at the neuromuscular junction increases the concentration of acetylcholine, displacing muscle relaxant molecules from post-junctional nicotinic receptors, so competitive agonism. The concentration of acetylcholine is also raised at muscarinic receptor sites, including the heart, causing bradycardia, and salivary glands, causing hypersalivation. So neostigmine is always given in combination with an antimuscarinic. There's a premixed amp with glycopyrrolate to prevent these undesirable effects. A transient tachycardia may result from giving this mixture because the glycopyrrolate works a bit quicker than the neostigmine. You can only use neostigmine to reverse muscle relaxation when neuromuscular block is already wearing off. You can't use it to reverse a deep block like you can with sugammadex.